All right, so welcome to week 8. So this week's lecture is on chapter 6, Ethics in Public and Community Health Nursing Practice, chapter 7, Culture of Populations in Communities, chapter 15, Case Management, chapter 16, Disease Management, 17 is Public Health, Surveillance and Outbreak Investigation, 18 is program management, 19 is healthcare improvement in the community, and then chapter 28 is nursing practice at the local, state, and national levels in public health. So quite a few chapters this week. I will try to keep this lecture about an hour. I apologize ahead of time if it goes a little bit over. But we will start with chapter 6. Chapter 6 is ethics in public and community health nursing practice. So the objectives for this chapter are to describe a history of the ethics of nursing, discuss ethical decision-making processes, compare and contrast ethical theories and principles, virtue ethics, caring ethics, and feminist ethics, describe how ethics is part of the core functions of nursing and public health, analyze codes of ethics for nursing and for public health, and to apply the ethics of advocacy to nursing and public health. So we do know that the work of nurses in public health involves ethical activities. And so we look at right-based versus community-based ethical theories. So that's something that the struggle that nurses go through. And ethics itself is both a process for reflection and a body of knowledge that focuses on the study of morality or moral life. And so, think about, the American Nursing Association Code of Ethics, some of the factors that we need to consider when we're providing community health nursing practice, our ethics, advocacy, our evidence-based practice, quality of care, as well as professional collaboration and communication. Bioethics is the study of ethical issues in research, clinical care, or other areas in the life sciences using both normative and empirical methodological approaches. And so historically speaking, we have not made some great choices in the past. And so you can look, your book describes the Nuremberg trials, also the syphilis study that was done here in the United States, where we had some failure in our system and actually caused harm to people rather than good. And so here's, some of them. In 1893 is when the Nightingale Pledge first came. That was our first code of ethics for nursing. So when you get pins, you will say your Nightingale Pledge. And then these are just some other issues that occurred and some changes that were made throughout history. So we look at ethical decision making. Ethical issues can occur in any situation where there's a moral question or rightness or wrongness that underlie professional decision making and the beneficent care of our community, our patients. Ethical dilemmas are dilemmas and moral problems in which a person, group, or community can envision morally justified reasons for both taking and not taking a certain course of action. So when we look at ethical decision-making uses problem-solving processes. It's a guide to make sound ethical decisions that are morally justified. And so some of part of that ethical decision framework, we want to identify the ethical issue or what the ethical dilemma is. We wanted to place the ethical issues and dilemmas within a meaningful context We want to gather all of our information. And then if we need to, we can, rearrange whatever the dilemma is. We also want to consider appropriate approaches to actions or options, and then make the decision and take action. And then, of course, we go back and evaluate. And so there's a really good chart in your book that gives you the steps for making or the steps for an ethical decision-making framework. What affects ethical decision-making processes? And you can think of, just things that you've come across in, not only if you're practicing in healthcare now, or even, in other lines of work. What are some things that would affect it? And so, when we're looking at making those ethical decisions, we have to take the community as a whole, and make the decisions based on what is best for the majority of the population. So here's your ethical decision-making framework. Again, ethical issues or situations in which ethnic diversity can be judged in relationship to cultural standards. So whether, situations that put somebody at indirect harm, whether it's physiological or psychological or physical, situations in which cultural standards conflict with professional standards, situations where the greater community's values are jeopardized by values of a small culture within that community, or even situations where community customs may cause mild offense or annoyance to other committees. So think about, how we can help the community as a whole. It is difficult, and just like everything else, the majority of the people, we want to help the majority of the people and try to overcome the dilemmas and make the best decision that we can. So when we look at working in the communities, we, as healthcare providers or public health nurses, we want to increase participation in health promotion. We want to manage those chronic diseases. Again, not only is it going to influence or affect the individual person, but it's going to affect the community as a whole. And so go back to previous chapters when we looked at different situations, right? Making sure that people have clean water, that the air is clean, that we have good, public safety, and we're trying to decrease the risks of the spread of communicable diseases, and keep as many people happy and healthy as possible. Ethical principles and theories that are related to ethical decision making. We have consequentialism, which that is the action that one produces the greatest amount of good or the least amount of harm in a given situation, which is your utilitarianism. That's a consequentialist theory that is associated with outcomes or consequences in determining which choice to make. With this, the priority is to maximize benefit and minimize harm, right? So what's the greater good here? Deontology is a theory of duty, holding that some features of actions other than or in addition to consequences make actions right or wrong. So this is based on people should always be treated as ends in themselves and never as a means. And then we, of course, have our primary principles of respect for all and distributive justice or social justice, right? So when we look at, autonomy, what is autonomy? It's, giving power back to the person in order to make the appropriate decisions. Non-maleficence, no harm is done, right? So we're not doing any harm. Beneficence is maximizing possible benefits and minimizing those possible harms. Justice is, or distributive justice, that is fair distribution of the benefits and burden in society based on the needs and contributions of its members, right? So when we think of justice, right, it's doing the same for everybody. Other, your other ones, your virtue, your feminist, your care ethic theories, um, excuse me. Virtue ethics is one of the older theories out there. Virtue ethics seeks to enable persons to flourish as human beings. And so think about, what kind of person you are, what kind of person that you can be. Um, Virtues are acquired excellent traits of characters that dispose humans to act in accord with their natural good. So, like your compassion, your trustworthiness, your integrity, right? Those would all fall under virtue ethics. When we look at feminist ethics. Feminist ethics reject abstract rules and principles. So it's pertinent to public health because it recognizes the role of political and social structures in health. And we know that feminists advocate economic, social, and political equality. And so in your text, there are charts on how to apply the care ethics decision process as well as the feminine ethics decision process. So when we look at ethics and the core function of public health nursing, it's almost like using your nursing process, right? We're going to do that assessment first. Assessment is collecting data on the population. We're monitoring population's health status. We're making information available about the health of the community. And so the key tenets here is going to be your beneficence and your non-maleficence, right? Beneficence, again, doing good, maximizing the benefits, minimizing the harms. And so what are some things that we can do? Um, are the people assigned to develop community knowledge adequately prepared to collect groups, information on groups of and populations? We look at policy development, right? We need to use these. They are critical to the development. The public health nurses are critical to the development of policies. And so when we look at policy development, right, we're looking to achieve public good, what service to others over service to self, what is ethically good policy as well as moral leadership. So you have to, what's a good policy? What's a right policy? What's a bad policy? What's going to provide for the overall good of the community. We look at assurance, that is making sure that essential community health services are available, including essential personal health services for those who would otherwise not receive them, and that there's competent public health and personal health care workforce. And with this, we look at justice, right? When we look at that distributive justice, making sure that, what is available for some is available for all. You know, that's again, fair distribution of the benefits and burden in society based on the needs and the contributions of its members. So all persons should receive essential personal health services. And we need to be able to provide competent care and be available to them. And that is one of the goals that we have had here in the United States, is to ensure that all members, or all people, all citizens of the United States have access or equal access to healthcare, as well as health insurance. So with your objectives for Healthy People 2030 regarding access to health services, we want to reduce the proportion of people who can't get medical care when they need it. We want to decrease the proportion of adults who report poor communication with their healthcare provider. And we want to increase the proportion of adults whose healthcare providers involve them in decisions as much as they wanted. So we look at the nursing code of ethics. The code of ethics was made by the American Nurses Association. It contains 9 provisional statements that address the moral standards that delineate nursing values, goals, and obligations, and serves 3 purposes. So the 3 purposes: it is a distinct statement of the ethical values, obligations, duties, and professional ideals of nurses individually and collectively. It is the profession's non-negotiable ethical standard, and it is an expression of nursing's own understanding of its commitment to society. So you can go to the American Nurses Association and you can look and read the nursing code of ethics. It's pretty well outlined. When we look at applying the public health code of ethics, this identifies the ethical practice of public health, ethical considerations, preventing harm, doing no harm, promoting good, respecting both individual and community rights, respecting autonomy and diversity, providing confidentiality, competency, trustworthiness, and advocacy. We know that community health nurses are concerned with protecting, promoting, preserving, and maintaining health, as well as preventing disease. And those concerns reflect the ethical principles of, both promoting good and preventing harm. So we're balancing the individual rights versus the rights of the community. And that's one of our biggest challenges in public health. Community health nurses also address the challenges of autonomy and providing ethical care. So when we look at clients' rights, we know that patients have the right to information disclosure, privacy, informed consent, information confidentiality, participating in treatment diseases, and then even as, community health nurses, that if we're participating in research, it's important that we use those ethical decision-making to promote quality or to promote client rights when we're doing that. So advocacy is one of the most powerful ethical concepts in nursing. It's the application of information and resources to affect systemic changes that shape the way people live in a community. It's an act of pleading for, supporting a course of action on behalf of a person, group, or community, public health advocacy. So, some of the, things that we do as advocates, as nurses, patients that are more autonomous have the right, or patients are autonomous. They have the right to make decisions affecting their own health and welfare. They have the right to expect a nurse-client relationship that's based on trust, that's based on collaboration, and shared respect, and considerate of their thoughts and feelings. Patients are responsible for their own health. It is the nurse's responsibility to advocate for resources and services that meet those clients' needs. And we can also, when we advocate for the community, for patients within the community or people within the community, we need to be assertive. We need to make sure that the priority is on our community's values, and that we're willing to progress through the chain of command to get what we need to get done. We work as advocates for communities and populations whether it's to, change healthcare systems to make them more accessible, or to improve quality of life within the community. So here's public health advocacy. So some of the things that, we would do: identify problems within the community, um, collect the data that is necessary, develop endorsing regulations within the community, enforcing policies, assessing the policy process. Was it effective? Was it not effective? And what do we need to go back? We looked at COVID-19. Disasters are going to disrupt the standard of care, and we know that, and we saw that with the COVID-19 pandemic. It had a huge impact on society as a whole. So chapter 7 is the cultural populations and community. And so right now we know that the United States population has become increasingly diverse, with the influx of immigrants, as well as um, migrants that are coming from other countries for whatever reason that they are coming. It has increased the diversity within the United States. Our patients or our clients often come from different cultural backgrounds. They may not recognize or understand the differences. We may not even, we may also have to find ways that we can interact with them through the use of interpreters, translators. And so we know that nurses have to be able to provide culturally competent care, and that is one of the core competencies of public health nursing. Even in any kind of nursing, we have to be able to provide culturally competent care. So cultural competence is one of the core competencies, like I said, and it's a combination of congruent behaviors, practice attitudes, policies that allow nurses to work effectively in cross-cultural situations. And so it's a skill that we develop in learning to respect individual dignity and preferences when working with members of another culture, as well as acknowledging that there are cultural differences. And so when we, think about some of, the environments that you work in, whether it's healthcare or not, right? There is a wide variety of, people that are different from you, or me, that we are come in contact with every single day. And it's important to understand how, how other cultures interact with the environment and with other people. So culture itself is just the beliefs, the values, attitudes, the behaviors, right, that are shared by a group of people, and passed down from generation to a generation. And so, we as nurses, as healthcare providers, we can use data about genetics, about family illnesses, the environment, lifestyle. That also helps us to identify patterns of disease and to prevent and treat disease, whether it's, related to a specific family, or if it's a specific subset of the community. So like think of like genetic disorders or disease processes that are more prevalent in certain races. And so there are guidelines that, when we look at culturally competent care, knowledge of cultures, education and training in culturally competent care, critical reflection, cross-cultural communication, culturally competent practice, cultural competence in healthcare systems and organizations, patient advocacy and empowerment, multicultural workforce, cross-cultural leadership, and evidence-based practice and research. And so Purnell developed the Purnell theory and model for culturally competent care, and there are 11 assumptions. Um, and so all healthcare professionals need similar information about cultural diversity, and they share concepts related to global society, family, person, and health. No culture is better than any others. They are just different, and there are core similarities among cultures with differences within, between, and among cultures, and cultures change slowly. The variant cultural characteristics determine the degree to which one varies from the dominant culture, and individuals and families belong to several subcultures. Persons who participate in their choice of health-related goals, plans, and interventions are more likely to comply, and culture has a major influence on a person's understanding and response to healthcare. And then, of course, each person has the right to be respected for his or her uniqueness and cultural heritage. So when we look at culture and race and and ethnicity, culture is a set of values, beliefs, and assumptions about life, right? This is what's passed from one generation to another. It's individual, it's a group, it's an organizational reality. And so because that culture is transmitted from one generation to next. And so is, again, as healthcare providers, we need to have a basic understanding of different cultures in order to be or to practice culturally competent care. Race is a biological variation. And so these are things like skin color, your physical features, your hair texture. Individuals may be of the same race, but of different cultures, right? So that is important to understand as well. When you look at ethnicity, ethnicity is the shared feeling among a group of individual and relates to cultural factors like nationality, where you came from, your geographical region, ancestry, your language, your beliefs, your traditions. It reflects cultural membership. It's based on individuals sharing similar cultural patterns that over time create a common history. And so again, we look at, how do we provide for that cultural competent care? So we have to have knowledge of cultures. And so knowledge of cultures is, it can be very vast and it can be very extensive depending on the population that you work with. And so in certain areas, you may have, a higher rate of one type of one culture, um, and may become extremely familiar with that. In other areas, you may have multiple cultures that you have to become familiar with when you're providing those care. So the 10 guidelines for providing culturally competent care is knowledge of cultures, education and training, and providing that cultural care. Again, your critical reflection, your cross-cultural communication, your culturally competent practice, cultural competence in health systems and organizations, patient advocacy and empowerment, multicultural workforce, cross-cultural leadership, and evidence-based practice and research. So, when we look at critical reflection, even looking back and, what are your biases and things regarding different cultures, race, ethnicity, and how you can overcome those, put those aside in order to provide culturally competent care to your patients or to your community. We look at cultural diversity. That's the degree of variation that is among populations based on lifestyle, ethnicity, race, interest, across place and place of origin across time. So again, what is the, diversity within your community? And what are some of the, what's the word I'm looking for? Like I'll just use my community for example. So because I am from a community that has a lot of influx because we're in a huge military community. We have multiple naval bases, Air Force, Army, Coast Guard, Marines. We have it all here. And with that, we have an influx of people from other countries. And so here we have a high African population, a large Filipino population. Um, and so there, we get members from other military, like other countries' military that come. And so it's very culturally diverse in this area. And so really learning to know, like learning your community and knowing what you're working with really helps you to increase your cultural diversity. And like I said, each community is going to be different. So you're going to know what groups are more prevalent in your community based on, because you live there and you work there. And so then becoming really competent with those groups of people that you are going to work with. Some of the things that would be different, because not all cultures aren't the same, but they have some of the same basic organizing factors. So communication space, social organization, time perception, environmental control, biologic variance, um, and nutrition. And so, we'll take communication, for example. So we know verbal communication, right? That's the words, right? That we use to express ideas, and feelings. And so, in certain cases, in certain, with certain variations, right, there may be changes in meanings to words, there could be changes in pronunciation. Some, use humor, some talk fast, like I can talk really fast, some need to talk really fast. Nonverbal communication, that's our body language, right? That's our gestures that we use to convey our message. And so things like eye contact, body posture, facial expressions, touch, silence, those are all things that we as nurses use, or everybody uses, when we're communicating with members of, or any patient. Um, and so think about how some of these would affect somebody listening to you or talking with you. I am very much a hand talker. And so sometimes when I get overly excited when I'm talking about a subject, my hands tend to go a little bit more. Um, and so we just, you have to be cognizant of what your nonverbal communication is saying. Um, some cultures, respect silence a little bit more than others. Some people get uncomfortable when silence is used when we're communicating. So we do have to be cognizant of that as well. Personal space is another one. This is the area that individuals need between themselves and others to feel comfortable. And so this is super important to understand too. Some cultures are much more friendly. They're, more that they're okay being closer to you. Other cultures, they are going to respect your personal space. They will stand back. And so that's another thing, normally, most of us like our personal space. And then even since COVID, a lot of people have even increased their personal space, right? Because we told everybody to stay, 6 feet apart. And a lot of people have just kept on with that, even things like handshaking, right? A lot of people don't even handshake anymore since COVID, just because they don't, want any potential illnesses to be spread. When we look at social organization, that's the way a cultural group structures itself around the family to carry out their role functions. And so think of, like certain cultures, the female is the head of household, and some cultures, it's always the male that's the head of household. Um, And so we do need to be aware, and we need to work with them. I had a family, they were from Pakistan, I believe. Father was the head of household. Mom couldn't make any decisions. So even when it came down to like when we were taking care of the kids and getting their immunizations or, blood work or x-rays or anything, she was not allowed to make those decisions. She wasn't allowed to offer consent. She would have to call her husband, and we would have to explain to her husband, why we were doing, a lead level or a hemoglobin or a CBC. Um, and then he would make the decision for that. So these are some barriers to, certain cultures, and that's okay, because there are ways that we can overcome those. We look at time perception. Time perception is different either. Um, Cultures are considered to be future, past, or present oriented. So like American middle class, we tend to be future oriented. Um, there's other cultures that are past oriented, so they may focus more on wishes and memories of their ancestors to look to provide direction for current situations. Um, Environmental control, this is the relationships between humans and nature. So these are also really important to understand. Um, some of them, cultural groups might perceive humans as having mastery over nature, being dominated by nature, or having a harmonious relationship with nature. So if they believe that nature is dominant, they believe that they have little or no control over what happens to them. So they may not adhere to certain medical treatments, because, they don't think that they'll be, that anything will change. People that view human harmony with nature, they may perceive that illness is disharmony with other forces, and medicine can relieve the symptoms but cannot cure the disease. So they would seek treatment, because they believe that healing comes from within. But they also may look more towards like your natural therapies, your homeopathics, and that kind of thing. And then some cultures may even view their illnesses as punishments, and may have difficulty accepting care, from, those that don't believe the same as they do. We look at biological variations. These are the physical, the biological, and physiological differences that distinguish one racial group from another. And they occur in areas of growth and development, skin color, enzymatic differences, and susceptibility to disease, right? So we know that certain races are more or certain diseases are more prevalent in some in some cultures. Um, Even if you remember back in pharmacology, when there was a section on pharmacogenetics, and pharmacogenomics, it's, basically how certain medications affect, people of different races. And so those are things that are also, taken into consideration. Nutritional practices are as well. That's part of the assessment process for all families, because they play a role in the health promotion of some groups, right? Some cultures, preparation, eating food, or social activities. They come together to celebrate life events, right? And have foods as rituals. And so taking all of these, into consideration when we are providing care for members of those in other cultures. When we look at our social determinants of health, if you remember, those are the circumstances where all people are born, in which all people are born, grow, live, work, and age that shape health. And so the social determinants of health can disproportionately affect ethnically or culturally diverse groups. Um, and according to the Healthy People 2030, the 5 areas of social determinants are your economic instability, education, your social environment, your health and healthcare, and your physical environment. And so each one of these is important in how it affects the health of individuals, families, as well as communities. And so a lot of the topics that are in this week's lecture, we've had a little bit, information about. And so when we look at immigrant health issues, 44.7 million immigrants living in the United States. So 1 in 7 US residents is foreign born. We know that immigration has recently become very controversial. Um, and so that is, something that we will continue to deal with. About 1/3 of our immigrants are uninsured. Non-citizens are more likely to be uninsured. The median age of the US immigrant population was 45. And so we have to look at these patients a little bit differently in how we are going to provide healthcare for them, how we get the resources that they need. Um, they are often at risk for more poor health outcomes, right? Um, Especially now, even more. Um, the fear of immigration reinforcement may prevent them from seeking healthcare. They often live in low income, segregated neighborhoods. They're working in low wage occupations or even in those unsafe working condition situations, right? And so that puts them at even increased risk bears. And so, you know, a lot of times too, when they come to the United States, they have their own health risks combined with language barriers. They often have, different social, religious, and cultural backgrounds that are different from their healthcare providers here. So there may be a little bit, more of a misunderstanding. Um, Adults are going to adjust a little bit more slowly coming into the United States. It's a big change, I imagine, from other countries. Your children, your adolescents, they will adapt and adjust a little bit more easily. Um, but again, these are some things that we have to look at. So when we look at the types of foreign born, we have our legal immigrants. They are not a citizen, but they're allowed to live and work in the United States, right? So um, whether it's, they're here for work, they're here for school, they have, family here. Your refugees, those are those that are admitted outside of the usual quota restrictions based on fear of persecution due to race, religion, nationality, social group, or political views. We have the Refugee Act of 1980 that provided a uniform procedure for refugees to be admitted to the United States. Um, and then we have our non-immigrants that are admitted to the United States for a limited duration, and unauthorized immigrants are those that have, may have crossed the border illegally, or they were here and their legal permission expired. And they are only eligible for emergency medical services. So some of the factors that we need to consider when we're providing care for immigrants, um, financial constraints, they may not be insured, which that can also cause tension for them. Language barriers, right? Do we need to use an interpreter? We are required to have interpreters, professional interpreters available to to communicate with patients that may speak another language. We also need to recognize the differences in social, religious, and cultural backgrounds between the immigrant and the healthcare provider. The provider's lack of knowledge about high-risk diseases in the specific immigrant groups for whom they are caring for. And this is why that cultural competence is so important. Traditional healing or folk healthcare practices that may be familiar to their U.S. healthcare providers. And when working with immigrant populations, considering how our own background, our beliefs, and knowledge may be significantly different from those people receiving care. So some of the skills that we need for working with immigrant populations, self-awareness is super important. Identifying the client's preferred or native language. When we don't speak or understand what they're saying or in their language, that's when we need to use an interpreter so that we can have full and effective communication. And so interpreters should have knowledge of health-related terminology. Again, we don't like to use family members or friends as interpreters because they may, feel like they need privacy and they may not want to share any information with friends or family. Family members also can lack objectivity when relaying information to or from the client. And they also may, the family may also have difficulty understanding like medical language or medical terminology. Um, and then when we're choosing an interpreter, we need to take into consideration the patient's preferences, like especially when selecting the age and gender of an interpreter. So like, if it's female, a female, if it's a younger male, getting a younger male, or translator or interpreter. They also should not be from the same community as the client for confidentiality purposes. We also need to look at, the difference in socioeconomic status, religious affiliations, educational levels, different dialects when we're using interpreters. Again, we are mandated that, we do have interpreters available when working with someone who doesn't speak our language, even American Sign Language, right? If you have a deaf patient, having a translator or an interpreter for American Sign Language if they're, if you don't know sign language. Get to know the community where the immigrant client lives. Learn the health-seeking behaviors for your immigrant client and their family members. So, when you're asking them or their family members, you want to know who they are, who the family is, their parents alive, their grandparents, who they live with, even, things like that. When we're looking at getting to know the community, read about the culture for your clients, learn about, formal and informal resources, how to interact with different members or how to interact with members of that culture. Get to know some of the traditional practices and remedies used by families and communities. So do they use, the traditional or folk healthcare practices? Learn how the cultural subgroups explain common illnesses or events. Try to see things from the viewpoint of the client, family, and community and accommodate rather than squash the client's view. And then conduct a cultural assessment focusing on what is working, what is not working, and changes that need to be made to accommodate cultural norms and promote positive health behaviors. And so, when we're looking at doing a cultural assessment, it's, looking at their ethnic background, their religious preferences, their family structure, their language and literacy needs, their communication needs, their education, their cultural values, their food patterns, right? All of those things, as well as their, their beliefs or thoughts on medications, treatments, that kind of thing. And let's see. So what are some reasons why we should be cultural competent? And again, it's our culture often differs from that of the patients that are, that we are caring for. Um, and so that's, leads to a different understanding of communication, behaviors, plan of care. Um, Non-culturally competent care may increase the cost of healthcare, decrease the opportunity for positive client outcomes. And so we need to learn about the cultures of the clients that we're serving, and, the respect, um, and provide, develop that therapeutic nurse-patient relationships. When we look at Healthy People 2030, objectives related to cultural issues. We want to increase the proportion of persons with a usual primary care provider. We want to increase the proportion of adults whose healthcare provider checked their understanding and increase the proportion of adults with limited English proficiency who say their providers explain things to them. And so imagine how frustrating it could be if you went to a doctor speaking English and they did not understand what we were saying. It's very similar, right? If we were in a foreign country and we didn't speak their language and we had to have healthcare for some reason, right? It can be frustrating for us to, tell them what's going on with us and what our preferences are. The same for patients that coming to us that don't speak our language or different cultures. And so this is super important for us, like I said earlier, in order, do that assessment, what are the primary cultures within your community and get to know, what their preferences are, and about them so that you can provide that culturally competent care to them. Concepts of cultural competence, we have this, cultural awareness thing that, we really need to understand. It's understanding the other culture, that other cultures exist. And it's not only that, it's an in-depth, deep dive into our own biases, our own stereotypes, and our own prejudices that may influence our behavior. And so that's why I said it's important to learn about the cultural dimensions of the client. We need to understand our own behavior and how it either helps or it hinders us from, providing competent care to our patients that are from a different culture. We also need to recognize that health is expressed differently across cultures, and that culture does influence the individual's response to health, illness, disease, as well as death. When we look at cultural knowledge, that is information about organizational elements of cultures. Emphasis is learning about the client's worldview from an ethnic perspective. That helps to decrease misinterpretations. It also helps to facilitate their coordination with healthcare. We look at cultural skill. That's the integration of cultural awareness and cultural knowledge, to obtain relevant cultural data to meet the needs of those culturally diverse clients or patients. And so this is, understanding, the dimensions, touch allowed. We want to maintain, social or proper distancing, use of silence, eye contact, those kinds of things. We look at cultural encounter is the process that permits nurses to seek opportunities to engage in cross-cultural interactions with clients of diverse cultures, and to modify existing beliefs about a specific cultural group and avoid stereotyping. Um, and so, working with clients of other cultures is going to develop, you're going to develop skills and understanding about about that different culture. It's always best to do some research. And if you don't know something, there's nothing wrong with asking, right? If you don't want to offend anybody, and you can start off your conversation, I don't want to offend you. Is there anything that I need to do or not do to make you comfortable? When we look at cultural desire, that's the nurse's intrinsic motivation to provide culturally competent care. Um, we should want to, right, know about other cultures to make sure that we are providing that culturally competent care, not because we have to. We should want to as nurses, right? Because our goal, our job is to help people. And so that helps us just to be better healthcare providers. Other things that we can do to show cultural or to convey cultural sensitivity, address them by their last names unless they, tell you to call them by a different name. Make sure that you introduce yourself by name, explain what your position, your job is. You want to be authentic and honest about what is known or not known about their cultures. That's why I said best thing to do is always ask. Find out what clients know about their health problems, their treatments. You want to incorporate, as many of those clients' preferences and practices into their healthcare when we can. We don't ever want to make assumptions. We also want to encourage them to ask about anything that they might not understand. We also want to respect their values, their beliefs, their practices. We want to show respect for their support systems as well as provide health teaching materials in their primary language and at the recommended readability level. So, CDC, World Health Organization, some really good sites that you can go to and find information and education for your parents or for your patients in their native language so that you are giving them the appropriate oops, that you are giving them the appropriate information and something that they would understand. There is another box in your text, box 7.3, that is about developing cultural competence. And so it gives you some points to remember. We look at cultural preservation. That means nurse supports and facilitates the use of scientifically supported cultural practices from a person's culture, along with those from a biomedical healthcare system. So, think of like acupuncture, acupressure, cultural accommodation. That means the nurse supports and facilitates clients in their use of cultural practices when they are not harmful to the client. And then cultural repatterning means the nurse works with the client to help them reorder, change, or modify their cultural practices when those practices are harmful to them. Cultural brokering is advocating, mediating, negotiating, and intervening between the client's culture and the biomedical healthcare culture on behalf of the clients. So you have to understand your culture and your client's culture, and to resolve or decrease problems that result from individuals in either culture not understanding the other person's values. Things that inhibit cultural competence or inhibitors to developing cultural competence. Stereotyping, right? That's attributing certain beliefs and behaviors about a group, to a specific individual without even without paying attention to any, individual differences. Prejudiced is having a deeply held reaction, which is usually negative, about another group or person. Racism is a form of prejudice, refers to the belief that persons who are born into a particular group are inferior. Ethnocentrism, right? That is that our own group is basically the best, right? And so sometimes, they have an inability to accept different worldviews, which leads them to devalue the experiences of others. Um, we also have cultural blindness, which is the tendency to ignore all differences among cultures, right? So that the differences don't exist. And as a result, they treat all people the same, which in a sense that is right, that's justice. But in a cultural sense, we still need to respect and understand the cultures in order to provide them for the best care possible. Um, Cultural imposition is the belief in one's own superiority, and the act of imposing one's values on others, right? So, if you're one culture, it's basically pushing your culture on somebody else. Cultural relativism, is that they recognize that patients have different approaches to their health and that each culture should be judged on its own merit and not on our personal beliefs. A culture conflict is a threat that may arise from a misunderstanding of expectations between clients and nurses when either group is not aware of cultural differences. Um, and then cultural shock is the feeling of helplessness, discomfort, and disorientation experienced by individuals attempting to understand or effectively adapt to another culture that differs in practices, values, and beliefs. And it results from anxiety caused by losing familiar sight, sounds, behaviors, right? So again, they're coming into our country, and we are much different than other countries. And so, it can be a little bit of a shock to them, when they come. So doing a cultural nursing assessment, again, we want to look at their ethnic background, their religious preferences, their family structure, their language, their literacy needs, their communication needs, their education, their values, their food patterns, what their health promotion and health maintenance practices are, what types of health practitioners do they use, and what medicines, remedies, treatments, and therapies that they use or have used in the past. And so we're going to collect that self-identifying data, and then ask a whole bunch of questions, right? We want to be sensitive, and be in tune with verbal and nonverbal communication. We also want to know about what resources are available in the community, such as schools, churches, clubs, hospitals, tribal councils, residents, bars, taverns, all of that stuff. We also want to know the specific areas to focus on, and then, know the appropriate questions to ask. If we need to use an interpreter, we use an interpreter. We can even talk to leaders within the community, and just be sincere and open. And so again, if you don't know, just ask them. Most of the time they're going to be very willing to provide that information to you. And so in depth, this is kind of what I was saying. The data collection, we're looking at the self-identifying data, right? The questions, the nurse identifies cultural factors that can influence organizing phase. That's where we're going to take all that data, and identify areas of differences, right, between their needs and what the Western medicine is. Talked about that. And then, so, building the culturally competent organizations. So organizations have a culture that includes policies, procedures, processes that incorporate certain values, beliefs, assumptions, and customs. And so a culturally competent organization has five essential principles. They value diversity, they conduct cultural assessment, they understand the dynamics of difference, they institutionalize cultural knowledge, and they adapt to diversity. So when we're looking at building those culturally competent organizations, these are some of the things that we're looking at, right? Who lives in the community? What kind of diversity exists? What kind of relationships are established between cultural groups? Are the different groups organized? What struggle exists between cultures, within cultural groups? Are they openly recognized and talked about? Are there efforts to build alliances and coalitions? And what issues do the different cultural groups have in common? Talked about those. All right, so that brings us to the end of chapter 7. So chapter 15 is case management. Um, so managing populations, by an integral system is essential. So when we look at population management, it includes wellness and health promotion, illness prevention, acute and subacute care, chronic disease, rehab, end-of-life care, care coordination, community engagement. So case managers and care coordination are at the core of population health strategies to improve the community outcomes. So population health management can maintain and improve physical and psychosocial status of clients through cost-effective and customized solutions. So we can coordinating and transitioning care helps to reduce costs and gaps. We support evidence-based practice, select quality care that is culturally competent, and provide disease management and self-management educational programming. So case managers or case management is indicated for, promoting interprofessional services, increased patient family involvement, helps to decrease costs by improving client outcomes, provide education to optimize health participation, helps to reduce gaps and errors in care. Again, applying evidence-based protocols and pathways and advocate for quality services and client rights. So the Affordable Care Act, which we've heard of before, endorses the use of integral systems to obtain emphasis on population health management across the continuum. Management is shifted from inpatient care as the point of management to primary care providers, right, as the point of entry. Care management services and programs provide access and accountability, and successful outcomes are measured by systems performance and pay for performance for providers to meet the needs of the populations. And so population management, again, we're going to assess the needs of the clients through health histories, use patterns, risk factors, create benefits and network designs to address those needs, prioritize actions to produce a desired outcome. We want to select those evidence-based programs, right, related to wellness, prevention, health promotion, demand management, patient and client engagement, educating the population. So we look at Healthy People 2030. The Healthy People 2030 goals are a social mandate for healthcare. And so we're thinking that care coordination and planned transitional care will be essential intervention that's going to be provided by nurses. And many of the interventions that we use with clients in healthcare systems will further those 2030 objectives. And also the Case managers and community public health nurses have the following core values: increase the span of healthy life, reduce disparities in health among Americans, and promote access to care to preventative services. So we look at the Healthy People 2013 goals. Regarding access to care, we want to reduce the proportion of people who can't get medical care when they need it, reduce the proportion of people who can't get prescription medications when they need them, increase the proportion of people with a usual care primary care provider, increase the proportion of adults who get recommended evidence-based preventative care, and increase the proportion of adults whose healthcare providers involve them in decisions as much as they wanted. So care management is a healthcare delivery process that helps achieve better health outcomes by anticipating and linking populations with the services they need more quickly. And under care management, we have things like utilization management, we have critical care pathways, case management, disease management, and demand management. And so, I was trying to see, okay. So utilization management attempts to redirect care, monitors the appropriate use of provider care and treatment services for both acute and community and ambulatory services. Your critical pathways, those are activities that can be used in a timely sequence to achieve desired outcomes of care. And so a lot of times, even like in your hospitals, you might use critical pathways in certain situations, in certain disease processes that are going on. Disease management, those are activities to coordinate healthcare interventions and communications for populations with disease conditions like diabetes and asthma. They work with providers and consumers to educate on self-care, shared decision-making, knowledgeable use of medications. And then demand management seeks to control use by providing clients with correct information to empower them to make healthy choices, use healthy and health-seeking behaviors to improve their health status, and make fewer demands on the healthcare system. So case management, which is different from care management. Case management involves activities implemented with clients in the system. They build on the traditional nurse's role. They adapt new competencies for managing the transition from one part of the system to another, or even to go home. And it's provided by nursing, social work, and rehab. And there's other types. So case management uses communication, available resources to provide safety, quality care, and cost-effective outcomes. And so case management is pretty complex. I don't know if anybody's ever worked in any kind of case management, but they do help to coordinate activities on multiple providers, payers, and setting. So think of, someone that has, a complex medical need, whether it's diabetes or, like we had case managers for some of our asthmatics. We had some for, obviously our newly diagnosed diabetics. We also had case managers for kids with like cerebral palsy. I'm trying to think. There was a couple other ones and I can't think off the top of my head, but it helps them, it helps the families, it helps them to like schedule appointments. They may need, help with transportation. So they do help to coordinate activities and increase communication. And so when we look at, if you have, let's say you're a newly diagnosed diabetic, you have your primary care, you have your endocrinologist, maybe you even have a nephrologist, and scheduling appointments, making sure that you get the appointments, scheduled, that you get to your appointments. This, can be very overwhelming to someone that has a newly diagnosed disease, in some cases, even if it's a chronic disease. But, this case managers can really help to bridge that gap. They also can, provide education. Um, when we look at, some of these newly diagnosed, um, you know, if they don't know what to do, if they don't have the proper knowledge of the disease process and how to manage it, maybe they're overusing their healthcare. Maybe they're calling their doctor's office or they're going to the emergency room, or, they're not understanding what they need to do. This is what case management does. It does kind of help to bring all of that together. There are a couple different care management models. You have your transitional care model and you have your aging in place. Transitional care bridges the gaps between services, providers, and settings. So they provide evidence-based interventions to improve communication and transfer of information across services. They enhance post-acute care follow-up, decrease gaps in care by using a single provider. So some of the essentials of your transitional care model would be medication management, transition planning, engagement and education, information transfer, follow-up care, provider engagement, and shared accountability across providers. In a rural setting, maybe a little bit different because they have fewer organized community-based systems. There may be a larger geographical distance to get to a healthcare provider. Population's more dense, finances, right? We think of the rural population. They may have lower socioeconomic status, different values. Their social organization is different in a rural versus a urban setting. So we look at case managers. It can be very labor intensive, time consuming, and costly. Um, they need to have knowledge of the community resources, financing, whether it's health insurance or is it out of pocket. They need to have good written and oral communication and documentation skills, negotiation and conflict resolution skills, critical thinking processes to identify and prioritize problems from the view of both the provider as well as the client. And they need to be able to apply evidence-based practice and outcome measurements. And so in your textbook, there is a box about the nursing process and case management. So it kind of goes through the nursing process on how it applies to case management itself. The 6 rights of case management are right care, right time, right provider, right setting, right price or value, and right outcomes. Um, and so they do develop care management plans. Um, these are things like critical paths, critical pathways, care maps, nursing care plans, things like that. The standards of client care, standards of nursing practice, your clinical guidelines, they all use evidence-based practices. Um, and so under that, we have disease management. Um, disease management programs, that's an organized program of coordinated healthcare interventions. Um, they also use consensus-driven performance measures and scientifically based evaluations in their clinical outcomes. And so this disease management focuses more on the natural progression of disease in a high-risk population. So it's a whole person model. And it can, be based on a singular disease. So your diabetics, your asthma, um, it just really kind of depends. If the disease management can give the clients the tools they need to better their lives, right? Again, if you're newly diagnosed with, even, you know, maybe not a life-ending disease, but asthma, diabetes, heart failure, kidney disease, liver disease, any of those things. It can be overwhelming. And so the goal, is to prevent future disease and complications through those secondary and tertiary interventions. They also, disease management programs also may help to reduce emergency room visits. Um, may help to, reduce inpatient days, rehospitalizations. They generally have a greater client satisfaction as well. Um, so disease management it's a complex. I worked with a bunch of disease managers as well as case managers. And their role is rough. There's, depending on what their patient load, um, they have a lot to do in helping them. Sometimes, even just helping them schedule appointments can be timely. Especially now, even after COVID, it's still hard to even get into some of the um, specialist office. Usually if they're, or if they're being discharged from the hospital with disease management, usually they won't discharge if they, without having an appointment already scheduled. But things happen. What if it needs to be rescheduled? What if the provider cancels? And so there's, what if, um, there's a lot of things that can be what ifs. And so these case managers and disease management really help these clients to get all of their ducks in the row so they get to the appointments they need. They understand the information that's being given to them from their providers. So there's a lot of education that can go on as well. We look at life care planning. That is another tool that that they use in case management. It looks at the current as well as the future needs of the patient that has a catastrophic or chronic disease. And so, it's not just about what is now, like what moving forward. And these, again, they're usually for catastrophic illnesses or adverse events from professional malpractice or accidents and injuries. Or even if they had an injury when they were younger and now they have changes in their resource requirements as they get older. So things like your spinal cord injuries, your TBIs, your chronic pain, amputation, cerebral palsy, um, all of that. Um, and utilizing technology to optimize the delivery process. So think of how technology plays a part in, how do we provide our care. Things that we can do to ensure that we are providing high quality care, provide access to easily understood information at their literacy level. Remember that the patient is the source of control and that patient and family engagement is critical. Provide access to appropriate specialists with coordination and communication, transparency, ensure continuity of care. Provide access to emergency services when and where needed. Disclose any financial incentives that could influence medical decisions and outcomes. Prohibit gag clauses. Provide anti-discrimination protections. Provide an internal and external appeal process to solve grievances and make decisions on the basis of evidence. So, advocacy, there's that word again. Advocacy, the definition of nursing includes advocacy. So nursing is a protection, promotion, optimization of health and abilities, prevention of illness and injury, alleviation of suffering through the diagnosis and treatment of human response, and advocacy in the care of individuals, families, communities, and populations, right? So one of our biggest things, we advocate, the nurse advocate makes the client's rights the priority. And so our aim is to promote the client's autonomy as well as self-determination, right? So it's not our goal to tell them what to do. We want to give them the information so that they can make a proper informed decision for themselves. So the process of advocacy, the goal is again to promote self-determination, right? And patient empowerment. Um, and so informing, giving them the information that they need to make that informed decisions. We want to be objective and give them the tools that they need in order to make that decision. Again, we need to understand what their perception of the situation is, what's their understanding, what's their literacy level, what are their cultural values, their ages, any disabilities that may interfere with learning. We want to provide correct information. We want to communicate that with them at their literacy level. If we need to use interpreters and translators, we do that as well. We can use media sources, we can use teach back methods. We also want to look at financial, legal, and ethical issues. And then, of course, any consequences of the decision. Supporting is upholding their right to make a choice and act on it. Affirming is based on an advocate's belief that a client's decision is consistent with the client's values and goals. So the advocate validates that the client's behavior is purposeful and consistent with the choice that was made. When we look at skill development, skills needed by the nurse advocate are, we need scientific, technical, relationship, and problem solving knowledge and skills. So advocacy applies nursing skills of communication and competency, promote client self-determination. Systematic problem solving, that's your ADPI or your nursing process that we use. Your illuminating values, people's values affect our behavior, their feelings, their goals. And so as an advocate, we need to understand their values. Again, this is where you need to ask, what are the things that they value? Generating alternatives. This is your problem purpose expansion method, right? So what is the problem? It's a brainstorming technique that, it looks at the problem, the needs, the desires, as well as the consequences. And then the impact of advocacy that empowers your patients, right? That are able to participate in the problem-solving process. They make decisions about their healthcare. They know that they have their rights. And so giving them the information, we are not making the decision for them. We are giving them the accurate information so that they can make an informed decision regarding their care and that they are essential. They're the center of their care. Conflict management. Conflict management, as a case manager, right? They can help clients manage conflicting needs as well as scarce resources. It is a mutual benefit with limited loss. That's the biggest goal. So techniques for managing conflict, using a range of active communication skills, detecting areas of agreement and disagreement, determining the abilities to collaborate, as well as assisting in discovering alternatives and activities to reach a goal. So negotiation, right, that is, kind of meeting in the middle, right? It's used to move conflicting parties towards an outcome. Um, and assertiveness is the ability to present one's own needs. Again, there's big difference between assertiveness and aggressiveness. And then cooperation is the ability to understand and meet the goals of others. And so some of the other categories of behaviors that are used in conflict management, like competing, accommodating, avoiding, collaborating, compromising, those are all in your textbook. And so collaboration is a highly interactive and interdependent process in which people work together, sharing resources or even a vision for a common goal. And so the goal of communication in the collaborative development process is to amplify, clarify, and verify all team members' points of view. And so they must, need knowledge and skills about the clients, their health status, their resources, their treatments, their providers, their complex needs between the client and the family, interpersonal, medical, nursing, and social dimensions, and then team members and leadership skills. Issues in case management. Liability. Liability concerns of case managers exist when the following conditions are met. The provider had a duty to provide reasonable care, a breach occurred through an act or omission to act, or the act or omission caused injury or damage to the client. And so case managers need to strive to reduce risks. They need to practice within acceptable practice standards and limit legal defense costs. And so 5 general areas of risk for case management, liability for managing care. So they failed to obtain all pertinent records. They failed to have cases evaluated. They restricted access. So there's a variety of areas that are a risk for case managers. There's a box in your book. It is box 15.6. Other ethical issues, of course, are going to be your autonomy, beneficence, fidelity, justice, non-maleficence, and veracity. So how would a case manager hamper the autonomy? Again, our goal is to give them the information so that they can make an informed decision on their own. If we don't allow them to choose their own provider, beneficence, right, or doing good, can be impaired when excessive attention to it containing costs supersedes the nurse's duty to improve health or relieve suffering. Fidelity is faithfulness to the obligation of duty, in this case to the client, by keeping promises, remaining loyal. Duty to clients to secure benefits on their behalf and limit unnecessary expenditures can create dilemmas when the goals are not uniform. Justice, it's right, equal distribution of healthcare. Your non-maleficence is do no harm. When case managers incorporate outcome measures, evidence-based practice, and monitoring processes in their plans of care that, they can do that's addressed. Veracity is absolutely necessary. There's no ifs, ands, or buts about that. And so, always be truthful. Biggest thing that you can do. All right, so chapter 16 is disaster management. So a disaster is an event that causes human suffering and demands more resources than are available in the community. It can be naturally occurring, man-made, or a combination of both. We have a natural disaster that causes technological failures. Disaster preparedness also includes planning for all types of hazards and establishes protocols for managing the surge of clients in the healthcare system. So again, disaster can be any natural or human-made incident that causes disruption, destruction, or devastation requiring external assistance. And we know that these ranges in size, they are usually expensive. There's lives that are affected, there's property loss, damage, and we can just, even within the last couple months, we can see the effects of natural disasters, even here in the United States, between tornadoes and hurricanes and flooding that has occurred, recently. Developing countries, they also experience disproportionate burden from natural disasters. They vulnerable groups are also excessively affected and less able to rebound. So think of you're very old, you're very young. Um, they may not have the ability to rebound from that. So a complex humanitarian emergencies, or CHE. These are emergencies that result from a humanitarian crisis in a country, region, or society where there's a total or considerable breakdown of authority resulting from internal or external conflict. Region or society where there's a total or considerable breakdown of authority resulting from an internal or external conflict, which requires an international response that goes beyond the mandate or capacity of any single and or ongoing UN country program. All right, so overcrowding and urban development also have increased human-made disasters. So overcrowding has led to civil unrest and riots. In addition, disaster recovery efforts are expensive. The costs are growing because of the number of people involved, as well as the amount of technology that must be restored. And so public health disasters can create needs across a large region or even around the globe. So think of like pandemics, that like COVID-19. They often have little or no advance notice, right? Your earthquakes, bioterrorism, they often have more casualties because of a lack of time to prepare or obtain treatment. And even though the number of natural disasters continues to grow, the number of lives lost has decreased. And this is because of better disaster forecasting, as well as our early warning systems. And so when we look at the, public or the when we look at public health surge, the pandemics, it's really just adjusting to a new normal. We know that COVID-19 has made a lot of changes in, society, and, how we even interact within, with each other. And so there are ways to prevent or manage how people and their communities respond to disasters. And so national disaster planning and response, we do have US agencies, as well as directives and systems, right? So we have the US Department of Homeland Security that was created through the Homeland Security Act of 2002, sorry. We have the National Preparedness Guidelines, and the National Response Framework. Those provide national doctrines for preparedness. It also includes the National Response Framework, the National Incident Management System, or NIMS. And then we have public health and medical preparedness, the National Health Security Strategy, and then we have Pandemic and All Hazards Preparedness and Advancing Innovation Act. And so we look at health and medical prepared or public health and medical preparedness, the national health security strategy. It's a national strategy that enables a level of public health and medical preparedness sufficient to address a range of possible disasters. And it does so through 4 critical components of public health and medical preparedness. So biosurveillance, your countermeasure stockpiling and distribution, your mass casualty care, and community resilience. The NHSS also emphasizes protecting the nation's physical and psychological health, limit economic losses, and preserve confidence in government and the national will to pursue its interests when threatened by incidents that result in serious health consequences, whether natural, accidental, or deliberate. And so the current plan has 3 overarching objectives. 1, to prepare, mobilize, and coordinate the whole of government to bring their full spectrum of federal, medical, and public health capabilities to support state, local, tribal, and territorial authorities in the event of a public health emergency, disaster, or attack. To protect the nation from healthcare effects of emerging and pandemic infectious disease, as well as chemical, biological, radiological, and nuclear threats, and to leverage the capabilities of the private sector. So when we look at the Healthy People 2030 objectives, almost every one of their objectives, because disasters affect the health of people, they have an effect on almost every one of the Healthy 2030 objectives. Disasters clearly affect the objectives that relate to unintentional injuries, occupational safety and health, environmental health, food and drug safety, immunization, and infectious disease, as well as mental health. And so when we look at the disaster management cycle, the disaster management has 4 stages: prevention, which includes mitigation and protection, preparedness, response, and recovery. So nurses have the skills to enable us to work in all aspects of disasters. So assessment, priority setting, collaboration, education, disease screening, mass clinic expertise. We also can provide public health services, make referrals, serve as liaisons, and provide psychological first aid, triage, and rapid needs assessments. And so the Healthy People 2030 goal is related to disaster mitigation. We want to increase the proportion of adults who know how to evacuate in case of a hurricane, flood, or wildfire. We want to increase the proportion of parents and guardians who know the emergency or evacuation plan at their children's school. And we want to increase the proportion of adults who prepare for a disease outbreak after getting preparedness information. So when we look at prevention, mitigation, and protections, prevention can be structural measures, right? So protecting our buildings, or it could be non-structural, like land development restrictions. Prevention also includes your man-made hazards and the ability to deter potential terrorists, detect terrorists before they strike, and take action to eliminate the threat. So some of our prevention activities may include heightened inspections, improved surveillance and security operations, public health and agricultural surveillance and testing, immunizations, isolation or quarantine, and halting chemical, biological, radiological, nuclear, and explosive threats. So when we look at nurses and their involvement in the aspects of prevention, so awareness and education, holding or attending community meetings on disaster preparedness, including informing the community about educational resources that are available to them, with organization and participation, in mass prophylaxis and vaccination campaigns to prevent, treat, or contain disease, and advocacy. Identifying environmental hazards, serving on public health team, supporting actions and efforts for effective building codes and proper land use. When we look at preparedness, think about it. Personal preparedness, you know, having a checklist, having emergency supply kits. How many of us have a plan should something occur? You know, emergency cash fund. Do you have a bag packed? What are you going to do with your animals? You know, that kind of thing. Just because we are in healthcare doesn't mean that we are not going to be affected by, right, a disaster. You know, we can be victims as well. And, you know, at the same time, we have to be able to provide care for others. That's going to put stress on us. So making, you know, whatever your emergency supplies, your personal checklist, always know evacuation routes. What are you going to do in the event of certain disasters? You know, do your kids, you know, you have children, again, pets, what are you going to do? Is super, super important. And then discussing these plans and having the plan in action, even doing like, drills, right? So, you know, so that everybody understands what their role is, and what to do. When we look at, you know, professional, and there's a chart in your book, How to Be Red Cross Ready, just to give some additional information. We also, you know, have to be considerate for seniors as well. How are we going to get, like, you may have seniors or elderly that live in your neighborhoods that may live alone. You know, what is their plan? Do they have a plan? What are some ways that community can assist them? Professional preparedness. Public health nurses are leaders in coordinating interprofessional teams to promote community health. And so when we look at disaster management at the community level, it's about population health. And we use the three core public health functions: assessment, policy development, and assurance. And so there are, you know, the American Red Cross does disaster training, your disaster medical assistant teams, or MRC. We call it MRC here, Medical Reserve Corps. And so the Medical Reserve Corps is something that is run out of the health department. And so we can, you know, we respond to, you know, whatever local disaster. And so like, for example, like during a hurricane here or something along, and we have like managing the shelters. We go out into the community and do blood pressure screenings. What else? Those are two of the things that I have done. Foodborne illnesses, outbreaks, they may help with that as well. It's just kind of it depends on whatever the needs are. And then, you know, when we look at, you know, if you want to, you can always look into the medical reserve teams. Again, it's not just nurses. It's like ours, we have people that are even in healthcare, we have doctors, we have veterinarians, because even there's certain times where they'll do like free vet services in some of our lower income areas. And so they'll bring a van, bring vets, do immunizations, they'll do like spade and neutering and stuff like that as well. So each, you know, I don't know how they're all set up, I just know how it is set up here. We look at community preparedness. The level of community preparedness for disaster is only as good as the people and organizations in the community make it, right? And so when we look at community preparedness, it involves all levels of government, public health agencies, hospitals, first responders, emergency management, healthcare providers, schools, universities, business, non-government organizations, right? And emergency management is responsible for developing and coordinating emergency response plans within their defined area, whether it's local, state, federal. So FEMA is the the Federal Emergency Management Agency that coordinates comprehensive all hazard planning at the national level. It assures a menu of exercises and plan templates to address plausible incidents in any given community. And so emergency management at the state and local level will work within, with their communities and response partners to provide opportunities to train, exercise, evaluate, and update disaster plans. And so disaster planning involves simplicity and realism with backup contingencies, right? Because you never know. They have it all planned out and then something happens. And of course, you have to have a contingency, right? A plan A, a plan B, a plan C. And so the National Health Security Strategy was to build community the purpose of the National Health Security Strategy was to build community resilience and to strengthen and sustain health and emergency response systems. Outcomes include community strengthening, integration of responses and recovery systems, and seamless coordination among all levels of the public health and medical system. When we have like disaster and mass casualty exercises. So the National Exercise Program serves to test and validate core capabilities. So participation exercises, simulations, or other activities helps them to, helps organizations validate their capabilities, as well as identify shortfalls. The Homeland Security Exercise and Evaluation Program was developed to help states and local jurisdictions improve overall preparedness with all natural and man-made and human-made disasters. So provides a standardized methodology and terminology for exercise design, development, conduct, evaluation and improvement planning, and it also helps assist communities in creating exercises that will make a positive difference in case there's a real incident that occurs. And so the next is response. So response, this is where we are going to activate that disease or that disaster management plan. And the first level is going to occur at the local level, right? So fire department, law enforcement, public health, emergency services. And then if the disaster, exceeds the ability of the local services, then the county or city will coordinate activities through an emergency operations center. The national response framework, once a federal emergency has been declared, the national response framework can take effect, depending on the specific needs that arise. The NRF was written to provide an approach to domestic incidents in a well-coordinated manner, enabling all responding entities the ability to work together more effectively and efficiently. And then we have our National Incident Management System, or NIMS. That's the national platform for disease response. It also includes universal protocols and language. It provides a consistent nationwide approach and vocabulary for multiple agencies or jurisdictions to work together to build, sustain, and deliver the core capabilities needed to achieve a secure and resilient nation. When we look at the response to biologic incidents, we know that those they pose a high risk to public health. Chemical terrorist attacks require a different response. The 5 components of a comprehensive public health response to outbreaks of illness are detecting the outbreak, determining the cause, identifying factors that place the people at risk, implementing measures to control the outbreak, and informing the medical and public communities about treatments, health consequences, and preventative measures. So identifying the chemical or biologic agent is going to be the first priority. And that's vital to protect healthcare workers and any others that are affected. And so some of the other biodefense programs, BioWatch is an early warning system for biothreats. It uses an environmental sensor system to test the air. BioSense is a data sharing program to facilitate surveillance of unusual patterns or clusters of disease. Project BioShield is a program that develops and produces new drugs and vaccines as countermeasures against potential bioweapons and deadly pathogens. Cities Readiness Initiative is a program that aids cities to increase their capacity to deliver medicines and medical supplies during a large-scale public health emergency, whether it's a bioterrorism act, nuclear accident. And then the Strategic National Stockpile is managed by the Centers for Disease Control, with the capacity to provide large quantities of medicine and medical supplies to protect the American public in a public health emergency, which may include bioterrorism. We look at how disasters affect communities. Pain, suffering, they lose their possessions, they may be injured, they may have lost loved ones. Can't put a measure on that. When disaster hits, right, most everybody in the community is going to be affected, whether it's physically or emotionally, depending on the type, the cause, the location of the disaster, the extent of the damage, how long it lasts, the amount of, any pre-warning that was provided. And so the first goal of any disaster response is to reestablish sanitary barriers as quickly as possible. Right? Water, food, waste removal, vector control, shelter, safety, those are all our basic needs. And so finding ways, how to establish those basic needs during a response. Stress reactions or traumatic events can cause moderate to severe stress reactions. Individuals react to the same disaster in different ways, right? Nobody's going to react to what's going on in the same way. It depends on their age, their cultural background, health status, social support, right? Their adaptability to stress or a crisis. And so there's a nice box in your textbook. It's 16.4 that will know when to seek help, tips for survivors of a disaster or other traumatic event, and managing stress. So there's a nice good book. Those that are affected by a disaster as well may have an exacerbation of an existing chronic illness, which then, that can also be even more detrimental depending on what's going on. Some of the populations at greatest risk for disruption after disaster, your older adults, women, pregnant women, children, those with disabilities, you're undocumented, you're non-English, you're homeless, you're low income, chronic disease. So there's a nice long list. The effects of disasters on young children can be especially destructive. They may have some regressive behaviors. They also tend to re-experience images of the traumatic event or have recurring thoughts or sensations. And so, children not even immediately affected by a disaster can also experience effects from it just because they're always hearing about it from whether it's family, TV. The National Institute of Mental Health document titled Helping Children and Adolescents Cope with Violence and Disasters. What Parents Can Do is a really good resource. It provides guidance according to age groups. Another population that sometimes is overlooked is children that are in childcare facilities. They may not have any security against a disaster. And so we need to make sure that there's a plan in place for how the children can be reunited with parents if that should occur. So what's the role of a nurse in disaster response? It depends on the nurse's experience, their professional role in a community disaster plan, any specialty training. Flexibility is key. Nurses serve many roles within the community. They advocate, they assess and report any environmental health hazards. They should also, be aware of and report unsafe equipment, faulty structures, any beginning of disease epidemics. And of course, the public health nurse brings leadership, policy, planning, and practice expertise to disaster preparedness and response. And so assessment during a major or assessment during a disaster, um, elements of a rapid needs assessment. We want to determine the magnitude of the incident, any specific health needs of the affected population, establish priorities and objectives for action, identifying existing and potential public health problems, evaluate the capacity of the local response, including resources and logistics, as well as determining the external resources needed for priority action. In sudden impact disasters like tornadoes, earthquakes, may be more concerned with ongoing hazards, injuries, deaths, shelter requirements, clean water. So that's where your triage comes into play. Triage begins immediately, right? That's where we are separating casualties and allocating treatment based on, who's hurt the worst. Highest priority is given to individuals with life-threatening injuries, but also those who have high probability of survival once they are stabilized. And then second priority is given to victims with injuries that have systemic complications that are not yet life-threatening and could wait 45 to 60 minutes for treatment. And then last priority is given to those with local injuries without immediate complications who can wait several hours for medical attention. Nurses can also initiate or update an agency's disaster plan, provide education programs and materials regarding disasters specific to the area, can also organize disaster drills, provide updated record of vulnerable populations within the community. And so when we look at recovery, or actually let's, talk about us for a minute here, psychological distress of disaster workers. So we are nurses, and it doesn't, we're also human. And so, we are also going to feel not only, maybe not only may we be affected by whatever the disaster is personally, right? We're also dealing with, everybody else's stress. And so, we know that what we do as nurses can have a positive, profound effect on patients as well as the community as a whole, but it may also take a toll on us as well. And so we have to remember that self-care is super important, that you're getting rest, that you're eating, that you're using positive coping mechanisms, right? Maybe you need to, talk with a mental health provider, maybe support groups. But symptoms that signal a need for stress management assistance, being reluctant or refusing to leave the scene until the work is finished, denying needed rest and recovery, feeling overriding stress and fatigue, engaging in unnecessary risk-taking activities, having difficulty communicating, remembering instructions, making decisions, or concentrating, engaging in unnecessary arguments. Physical symptoms, tremor, headaches, nausea, cold or flu-like symptoms can also occur. Suppressing feelings of guilt, powerlessness, anger, other signs of stress will eventually lead to symptoms like irritability, fatigue, headaches. And so self-care is very important. Delayed stress reactions are those that occur once the disaster is over. Things like exhaustion or inability to adjust to a slower pace. Recovery is about returning to the new normal with the goal of reaching a level of organization that is as near the level prior to the disaster as possible. And that's usually the hardest part. And so this is where all the agencies will start to work together to restore institutions, rebuild, And so there, when we look at the nurse's role, um, we can, um, help initiate or update agencies' disaster plan, provide education. I already talked about those. I apologize. Um, but think of there's still going to be lots of things that need to be done in that recovery. You can still provide and coordinate care in shelters, provide stress counseling, assessing for like PTSD or delayed stress reactions, making referrals for psychological treatments. um so we look at the future of disaster management. Um, we will continue to plan and train in all hazards environment, regardless of specialty practice. The nature of disasters will always be unpredictable, right? And that unpredictability and the medical and public health surge requirements in disaster make prevention and preparedness activities on the part of individuals and communities even more important. So just to share, when I was in my bachelor's program, um, we had a hospital it was being built while I was in school. And so, um, toward the, towards the end of my program, the hospital was up and running and they, did a disaster drill. And I don't remember what the disaster was. I want to say it was like a bus, it was like a mass casualty. So I think they did like a bus accident, because they got kids from like the local high school. To participate. And so we were students, we were bachelor students, so we weren't employees. So we were there more as an observation, just to kind of see um, what it was like. And so, we got to watch their triage process and how they move people through the ER. So like those that needed to go to surgery, or those that were, they stabilized them in the ER. They sent them whether it was to like the ICU or if they had to go, they just went up to med surge, like watch that whole process. And it was really interesting to watch. We didn't get to sit through the debriefing, which is what we really wanted to sit through to kind of see, because we were students. We didn't know, what they were doing right versus what they were doing wrong. But a lot of times they'll publicize that information if a hospital is getting ready to run a drill. So it's always fun, not fun, and I guess it is kind of fun to kind of go and observe and watch how they do it. It was a really good learning experience. 100, I would 10 out of 10 recommend somebody to um go and watch a disaster drill, because it was very interesting how all the, everybody in the hospital, they all worked together and they each had their, specific jobs to do. But they also knew how to interact and communicate. And the site supervisor, I guess, I can't remember. They were all had walkie-talkies. They were all, and they took it like they didn't lollygag, like they didn't just go through the motions because they knew it was a drill. They actually really did work together. It was really, like I said, if you ever get a chance um to, participate or watch one, it was actually a really interesting process. All right, so chapter 17 is public health surveillance and outbreak investigation. And so disease surveillance has been around for a very long time. The US Constitution provides for police powers necessary to preserve health safety as well as other events. And those powers include your health surveillance. Um, and so it is important for us to be prepared to lead and be a member of a team if an unusual occurrence or event strikes the community. So disease surveillance is the ongoing evaluation, analysis, um, or the systematic collection, analysis, interpretation, and dissemination of specific health data for use in public health. It Surveillance provides a means for us to monitor disease trends in order to reduce morbidity and mortality, as well as to improve health. So some what's the word I'm looking for? Surveillance features. You have your event. The event is whatever the disease or whatever the outbreak is. We want to know the timing, the geographic distribution, those populations that are susceptible. Surveillance is built on understanding the epidemiologic triangle, right? So your agent, host, and environment, those relationships, and on the natural history of disease or conditions. And so surveillance, right? We focus on collection of process and outcome data. So your process data, that is what is done. Those are the services provided, the protocols. Your outcome data focuses on changes in health statuses. Bioterrorism is defined as the intentional use of microorganisms or toxins derived from living organisms to cause death or disease in humans or the animals and plants on which we depend. And so CDC does have a bioterrorism website that provides information about emergency preparedness and response information, not only for, healthcare providers, but also for the general public. It also gives information about specific bioterrorism agents. Your chemical terrorism, that is the intentional release of hazardous chemicals into the environment for the purpose of harming or killing. And so the CDC also provides chemical emergency preparedness and response information. We look at uses of public health surveillance. Public health surveillance can be used to estimate the magnitude of a problem, determine the geographic distribution of the illness or symptoms, portray the natural history of a disease, detect epidemics, define a problem, generate hypotheses, stimulate research, evaluate control measures, monitor changes in the infectious agents, detect changes in health practices and health behaviors, facilitate planning, and guide public health policy and programs. So again, the purpose of surveillance. And so, surveillance helps the public health departments identify trends in unusual disease patterns, establish baseline rates, set priorities for using scarce resources, develop and evaluate programs for commonly occurring and universally occurring diseases or events. Surveillance data are also used to develop policies that help to better protect the public from problems like emerging infections, bioterrorism, biological and chemical threats, injuries from problems like even motor vehicle accidents. Surveillance also makes it possible to have ongoing monitoring in place to ensure that disease and event patterns improve rather than deteriorate. When we look at collaboration among partners, a quality surveillance system requires collaboration, right? It's not just one person, it's not just one. So it's federal agencies, state agencies, local health agencies, hospitals, healthcare providers, medical examiners, veterinarians, pharmaceutical agencies, emergency management, law enforcement, ambulance services, urgent care, emergency department, right? It's a little bit of everybody. Such collaboration promotes the development of a comprehensive plan, as well as a directory of emergency responses and contacts for effective communication. And so there's our nursing competencies, since nurses are often in the forefront. We, will be in the surveillance process. So the nurse competency, the core competencies include assessment and analytic skills, policy development, program planning skills, communication, community dimensions of practice, basic public health science skills, leadership and systems thinking. So to be a participant in a surveillance and investigation activity, the nurse must have the following knowledge. So we need to be able to define the problem, determine the cause, identify a statement, identifying and understanding relevant data, using the data to address any community health problems, incorporate evidence in their decision-making, identifying risk. They also have to have policy program, right? Those policy program skills, those are planning, implementing, and evaluating policies and programs to improve community health and strategic plans. The phases of the nursing process linked to preparedness is a nice table in your book 17-1. So we look at data sources for your surveillance. Data sources are things like your mortality data. We can get, these are like your vital statistics, your death certificates, your medical examiner reports, your birth certificates. Mortality data can be gotten through the National Vital Statistics System. Your morbidity data, this is your notifiable disease reports, your lab reports, discharge reports, your billing data, outpatient healthcare data, specialized disease registries, injury surveillance systems, environmental surveys, sentinel surveillance systems. And so the goal is here for 2030. Healthy People's 2030 goals, increase the number of individuals trained globally to prevent, detect, or respond to public health threats, increase the number of globally important public health events that are tracked and reported, increase laboratory diagnostic testing capacity, surveillance, and supporting and reporting globally. We look at the Sentinel, sorry, I think I went to, no, I didn't. Okay, so we look at the Sentinel surveillance system that provides for monitoring of key health events when information is not otherwise available, or for calculating or estimating disease, morbidity, in vulnerable populations. So the registries monitor chronic disease. They can link information from a variety of sources to identify disease control and prevention strategies. Surveys then provide data from individuals about prevalence of health conditions and health risks. And then the surveys allow for monitoring changes over time and assessing the individual's knowledge, skills, knowledge, attitudes, and skills. So notifiable diseases. The National Notifiable Disease Surveillance System, or NDSS, and the standard care definitions. These, we do have a list of notifiable diseases, and there's a box 17.3 has a list of your national level reportable diseases. Now, these are at the national level. Down at, the state notifiable diseases, state requirements may differ, but not all the national notifiable diseases are legally mandated for reporting in a state. And so it may be a little bit different, where it is, but like for, most of your STIs, your measles, mumps, rubella, anthrax, botulism, salmonella, there's a nice long list of reportable diseases. We look at case definitions. A case definition provides understanding of the data that's being collected and reduces the likelihood that different criteria will be used for reporting similar cases of disease. So case definitions may include like clinical symptoms, their lab values, their epidemiological criteria, right? Did they have an exposure to a, known or suspected case of something? Each disease will have its own set of criteria based on what is known about the particular diseases. And then we can classify them as suspected, probable, or confirmed. We look at the types of surveillance systems. Surveillance. So we have passive system, Passive system case reports are sent to local health departments by healthcare providers, or lab reports of disease occurrence are sent to the local health department. Your active system, the nurse, at the health department may begin a search for cases through contacts with local healthcare providers and healthcare agencies. Your sentinel system, it monitors key health events when information is not otherwise available or in vulnerable populations to calculate or estimate disease morbidity. So within sentinel, like what really happened, what were the consequences, what was the outcome, has it happened before? And with your special systems, these were developed for collecting particular types of data, and maybe a combination of the passive, the active, and or the sentinel systems. Things like your oh my gosh, bioterrorism, your National Syndromic Surveillance Program, NSFP, promotes timely exchange and monitoring of data, including client encounter data from like emergency rooms, urgent cares, ambulatory care, and inpatient, as well as pharmacy and lab data. And then that real-time data is used as a potential indicator of an event, disease, or outbreak concern. So then we have our investigation. Excuse me. So the objects of an investigation are to control and prevent disease or death, to identify factors that contribute to the outbreak of the disease and the occurrence of the event, or to implement measures to prevent occurrence. And so, the problems, you have endemics, hyperendemics, sporadic, epidemics, pandemics, holoendemics, outbreak detection. So holoendemic in a population implies a highly prevalent problem that has commonly occurred early in life. And the prevalence of the problem decreases as age increases. Your outbreak detection, that's identifying an increase in the frequency of disease above the usual occurrence of the disease. Patterns of occurrence. So these are used to define the boundaries of a problem to help investigate possible causes or sources of the problem. So a common source outbreak refers to a group exposed to a common noxious influence, such as a release of a noxious gas. In a point source outbreak, all persons exposed become ill at the same time during one incubation period. With a mixed outbreak, or a mixed outbreak is when a victim of a common source epidemic has person-to-person contact with others and spreads the disease. Your intermittent or continuous source cases may be exposed over a period of days or weeks, like as a result of food poisonings. A propagated outbreak does not have a common source. It spreads gradually from person to person over time, over more than one incubation period. So that could be like the spread of tuberculosis. And so causal factors from the epidemiological triangle. Again, go back to that epidemiological triangle, right? We have the types of agents, the classifications of your agents. When do we investigate? An unusual increase in disease incidence should be investigated. And so there is a nice box to how to conduct an investigation in your textbook. And then there's also a nice box on how to recognize the epidemiologic clues that may signal a covert bioterrorism attack. There's level of preventions. So there's some really good information in chapter 17. All right, so chapter 18 is program management. So program management consists of assessing, planning, implementing, and evaluating a program. It's much like the nursing process. The process of program management consists of rational decision-making system designed to help nurses in making a decision to develop in a program, to develop a program, your assessment, where they want to be at the end of the program, which is your goal setting, how to decide what to do to have a successful program, your planning, how to develop a plan to go forward from where they start to where they want to be, which is your implementing, how to know they are getting there, which is a formative evaluation, and what measures to know that the program has successful outcomes, which is a summative evaluation. So community health planning is population focused, and it positions the well-being of the public to promote health equity, community empowerment, and social justice above private interests. And so specific examples and population focus would be your home health, your immunization and infectious disease programs, health risk screening for industrial workers, family planning programs. More complex group and community programs would be things like school health, occupational health and safety, environmental health, community programs aimed at preventing specific illnesses through special interest groups, disaster preparedness programs. And so programs are ongoing organized activities that become part of the continuing health services of a community or organization, whereas a project is an organized activity with limited time frame, like a health fair is along that line. Planning is the selecting and carrying out of a series of activities, right, designed to achieve desired improvements. With the goal of planning is to ensure that the healthcare services are acceptable, equal, efficient, and effective. And then, of course, evaluation, right? That's determining whether the service is needed and can be used, whether it is conducted as planned, and whether the service actually helps communities and populations in needs. So some of your benefits of program, or I'm sorry, I'm going to go back. Sorry. We look at program evaluation, a formative evaluation. That's an evaluation for the purpose of assessing whether the objectives are met or the planned activities are completed. And that begins with an assessment of the need for the program. And then, of course, it's ongoing. Your summative evaluation, this is an evaluation to assess program outcomes or as a follow-up of the results of the program activities. And it usually occurs when a program is completed or at a specific point in time. So the benefits of program planning. Benefits clients, nurses, employing agencies, the community. It focuses attention on what the organization and health provider are attempting to do. Assists in identifying the resources and activities that are needed, reduces role ambiguity, reduces uncertainty within the program environment. It increases the abilities of the provider and the agency to cope with the external environment. It helps the provider and the agency anticipate events. It allows for quality decision-making and better control over the actual program results. And so most of our planning today is strategic planning. And so it matches the client needs with specific provider strengths and competencies and agency resources. When we look at the program planning process, this is affected by governments, by cultures, by belief systems within the population. And program planning is required by federal, state, and local governments, as well as by employing agencies and others as well. So there is a nice chart in your book about how to develop a program plan, right? But it's describing the plan, formulating the plan. So you have the plan, you have the problem, sorry, you want to describe the problem, and then formulate the plan. So you need to assess the population, you need to establish program boundaries, assess their program feasibility, um, assess the resources that are available, determine what tools that are used to assess the need, conceptualize the problem, detail the plan, evaluate the plan, and then implement the plan. So definition of problem and need. That's the initial, that's the most right. The most critical one is to what is the problem, what is the need? And so the target population or client to be served must be identified and involved in designing the program. Program planners must verify that a current health problem exists and is being ignored or is being unsuccessfully treated. And so it's kind of like you're conducting a needs assessment. And so the needs assessment includes, what's going on with the community, what are the needs of the community, what are the problems that need to be addressed. Before implementing a health program too, we need to look at resources. So financing, personnel, facilities, equipment, supplies, right? Because we need to have the amount of funds to support the program, the number, available personnel as well. There must be a place to do it, right? You can't just say, oh, I'm going to go have a health fair on such and such and not have anybody to help you, not have funding for supplies, not have a place to have that health fair, right? So all of those things must be done during this process. Review of the literature. And so I'm not sure if anybody has ever done a review of literature, but that can be a little bit of an intensive process. That determines what approaches have already been used in other places that have similar problems. So you know you have an outbreak of, I don't know, I'm just going to use influenza because it's just easy. And you Google search, dealing with an influenza outbreak, right? So you can see what other areas have done within that area, within their community to minimize, or, we have like excessively high amounts of people that have hypertension or obesity, whatever it is. You're going to do a Google, you do a search, you review the literature to see what other places have, other places have done. And that's right. That's your evidence-based practice, right? We're reviewing the literature, seeing what has been implemented, how it has worked out, and then, we have that evidence-based. And then we can also evaluate possible problem solutions. We can use decision trees to help us do that. And then we want to choose our solution. So how do we what is our solution? How are we going to get there? Program management, again, it utilizes similar process to the nursing process. So table 18.1 in your book will give you a comparison of the nursing process versus program planning. Creating a successful program relies on careful assessment of the population. All stakeholders should then be involved. And then, of course, appropriate interventions should be implemented to achieve the goals and outcomes. And then an evaluation must occur in a formative as well as a summative nature to ensure that the intended goals and objectives for the programs were met. So some of the program planning models for public health, you have the PATCH, which is your planning approach to community health. You have your APEX PH, which is your assessment protocol for excellence in public health, and your MAP, you're mobilizing for action through planning and partnership. And so there is a chart box 18.3 that gives you the elements of all three of those public health planning modules. And then we have program evaluation that shows where the program is meeting it, whether the program is meeting its purpose. It should answer, are the needs for which the program was designed being met? Are the problems it was designed to solve being solved? In addition, we can do program audits or quality assurance audits. So with the program evaluation it's a systematic way to improve and account for public health actions by using methods that are useful, feasible, ethical, and accurate. And so there's 6 interdependent steps. So engage stakeholders, including those involved in the program operations, those served or affected by the program, and primary users of the evaluation. Describe the program, including the need, the expected effects, the activities, the resources, the context, the logic model. Focus the evaluation design to assess the issues of greatest concern to stakeholders while using time and resources as efficiently as possible. Again, we're going to consider the purpose, the users, the questions, the methods, and the agreements. We want to gather credible evidence, justify our conclusions by linking them to the evidence gathered and judging them against the values or standards set by the stakeholders. And then ensure use and share lessons learned. So that's, another part of it too, right? What is it? What's the one? Like start, stop, continue, right? What worked good, what didn't work. So what should we stop? What should we start? What should we continue? The formulation of objectives for program evaluation, we want to do our mission, which is our statement, our values. We want to have a goal. A goal is a statement that describes the general direction of logical responses to a need. The goals are also the basis for writing the objectives for the program. The objectives are concise statements that are described in measurable outcomes, time-bound terms, precisely what specific outcomes to be accomplished, measurable, right? The objective contains specific outcome anticipated that can be documented with collectible data. Time-bound means the objective contains the target date in which the specific outcome will be accomplished. Again, objectives should be realistic and attainable, just like with the nursing process. And then your action steps, right? Those are the steps that helped you to accomplish the objectives. And then what evaluation measures did you use? Sources of program evaluation. These are program clients, program records, community indexes. So program clients, those are used most often, like a client satisfaction survey. Your program records or clinical records, that's about the care that was given to the client, the results of the care. And then, of course, your epidemiological data, your common indices, your morbidity, mortality, your incidence and prevalence rates. So there is Healthy People 2030 goals for program planning and evaluation. The focus area is community public health infrastructure. The overall goal was to increase the proportion of local public health jurisdiction that have developed a community health improvement plan. So chapter 19 is healthcare improvement in the community. And so but pretty much this whole previous 8 weeks is about, right, making a movement to improve healthcare quality within the United States. And improving the quality can improve safety of care. It saves lives, cost reduction by using effective interventions, increase in client confidence in healthcare delivery, regardless of the setting. and then focuses on finding failures in the systems and not blaming others. So milestones in quality. So total quality management was a management philosophy that was I can't remember his name, back in the 1950s. It included focus on client continuous quality improvement as well as teamwork. And then the total quality management was replaced with a new concept, which is healthcare performance improvement. 1970s, we had the managed care organizations sought to help, reduce those healthcare costs. And we have your preferred provider organizations, your exclusive provider organizations, your point of service organizations. And then in 1972, we had the Social Security Act amended to establish professional standards review organization to mandate the process to review Medicare, Medicaid, and maternal and child health programs. It's a little bit of history. Healthcare quality and nursing practice. And so go back to Florence Nightingale, right? She called for a uniform method for collecting and presenting hospital statistics to improve data. She did a lot of things while she was around. In the late 1800s, we had a movement to establish nursing schools in the United States. In the 50s, we had quality improvement or measurement tools that were developed, FANUS nursing audit method, the American Nurses Association created the divisions on practice in 1966. In 1972, we had the Congress for Nursing Practice that developed standards for quality assurance programs, like JACO. And then we had the National Health and Quality Improvement Act of 1986. So what is quality? I mean, what is quality, right? By definition, it is defined by the client as the improvement of health status, and defined by organizations and providers as accurate intervention, the clinical context of care, and the skill of the provider. We look at quality healthcare, is doing the right thing for the right client and having the best possible possible results. Quality health quality and public health, the degree to which policies, programs, services, and research for the population increase desired health outcomes and conditions in which the population can be healthy. So approaches to quality improvement. Voluntary approach involves a large governing or official body's evaluation of a person's or agency's ability to meet criteria or standards through processes like accreditation or certification, credentialing. Your required approaches, those are used to manage a specific healthcare delivery system in an attempt to deliver care with outcomes that are acceptable to the consumer. So like your state licensure, accreditation, certification, your academic degrees. So like even, your licensing, your boards of nursing. And so there is a chart on table 19.1 that does give you it's a table about the approaches to quality improvement. We look at quality improvement in public health. um there's the community assessment and community health improvement plan, which is a systematic approach to address public health problems based on the results of a community assessment. And then of course we will develop the improvement plan to address the problems that we find. Your population health management, that is a model of care, addresses individual health needs at all points along the continuum of care, including in the community through participation, engagement, and targeted interventions for a defined population. And so performance monitoring. We look at performance monitoring. This is a continuous community-based process of selecting indicators that can be used to measure the process and outcomes of an intervention strategy for health improvement, making the results available to the community as a whole to inform assessments of an effective intervention and the contribution of accountable agencies. So, quality improvement is super important. Guidelines or protocols or statements of recommended practice developed by government and healthcare agencies and professional organizations. So when we look at evaluating healthcare performance, those of you that have worked in healthcare or have worked in healthcare prior, notice there has been a huge switch from quantity of care to quality of care. And so, there's, we look at even the rate, you go into, let's say somebody goes into the hospital and they have to have, I don't know, a hip replacement, okay, and while they're in getting their hip replaced, maybe something happens, either intraoperatively, postoperatively, and they develop osteomyelitis, right? So that is a healthcare associated infection. So it is going to utilize additional healthcare services, right? And so because that infection occurred, the patient didn't have the infection, right? Then the hospital is overall responsible for the cost of that patient's care, just like if somebody were to develop a catheter associated UTI or a central line infection, that kind of thing. When we look at methods for evaluating healthcare performance improvement, one of them is Donabadian structure process outcome model. Structure is evaluating the setting and the instruments used to provide care. So like the facilities, the equipment, the administration, qualities of the healthcare providers. Process is evaluating activities as they relate to standards and expectations of healthcare providers. And then outcomes are the change or result that occurs as the result of healthcare. The tracer method is currently used. It's a little bit more effective. The essential characteristics of the tracer method, a tracer or a problem that has definite impact on the client, well-defined and easily diagnosed characteristics, population prevalence high enough to permit adequate data collection, unknown variation resulting from use of effective healthcare, well-defined management techniques in prevention, diagnosis, treatment, or rehab, and it understood effects of non-medical factors on the tracer or the problem. So groups or populations for tracer outcome studies would have the following: shared health care issue, a similar intervention used to solve the issue, similar needs, be located in the same community, have a similar lifestyle, be at the same disease stage. Let's see, the Sentinel method is based on epidemiological principles. It's an outcome measure for examining specific diseases and the impact on health and economics of a population. So like this data can be collected like at the health department, through a state or local disease reporting system. We talked about the Sentinel method. There's a nice chart on how to conduct a Sentinel method. The Plan, Do, Check Act. It's 4 steps. Plan, which is plan ahead for change, analyze and predict the results, do, execute the plan, take small steps in controlled situations. Check is study the results of the plan, and act is take action to standardize or improve the performance process. your CHA, CHIP, your community health assessment, community health improvement models. That's more recent. They used to monitor outcomes of health agency services over a 3 to 5 year period. Oops. So we look at evaluation, interpretation, and action. So what are we doing? And so regular intervals for evaluation should be established. So performance improvement efforts can be analyzed and problems identified. Courses of action should be based on their importance, their cost, their timeliness. And then taking action is the final step in a quality improvement model. And then of course, follow up and evaluation of actions taken must occur for performance review to be effective. All right, and the last chapter, chapter 28, nursing practice at the local, state, and national levels in public health. So public health programs are designed with the goal of improving a population's health status, right? We know that. And so it also includes a community health assessment, community level interventions, analysis of health statistics, public education, outreach, case management, advocacy, record keeping, professional education, disease surveillance, emergency preparedness, compliance with regulations, right? Follow up population health problems. So like examples requiring follow up, persons with active untreated tuberculosis, pregnant women who have not catch prenatal visits, parents of under immunized children, families or individuals diagnosed with COVID, right? So those that work in public health, you're going to work with multidisciplinary teams, right? We know that. So roles of the different levels of government. So the federal public health agencies develop regulations that implement policies formulated by Congress and provide a specific amount of funding to state and territorial health agencies to do the following: provide public health services, survey nation's health status and health needs, set practice and standards, provide expertise that facilitate evidence-based practices, coordinate public health activities across state lines, support health services research. Each of the state and territories has a single identified official state public health agency that's managed by a state health commissioner. These agencies receive funding from federal agencies for the implementation of public health interventions. Your local public health agencies, their responsibilities vary depending on their locality, but they are responsible for implementing and enforcing local, state, and federal public health codes, ordinances, providing essential public health programs to a community. The goal is to safeguard the public health and to improve the community's health status. And so there's a box in your text, box 28.2, that gives you the local public health agents functions. And then we have the majority of local, state, and federal agencies are involved in all of these. Collecting, analyzing vital statistics, receiving reports about abuse, investigating and controlling communicable diseases, protecting the environment, planning and responding to natural and human-made disasters and emergencies, right? So that long, yes. And so we'll look at histories and trends of public health. So people are living a little bit longer than they used to. So increased life expectancy, public health has expanded beyond communicable disease prevention, Medicaid managed care. As a result of Medicaid managed care, many of the public health agencies were no longer providing personal health care services. So the public health agencies kind of did a shift to or began to shift emphasis from a focus on primary health to focus on more public health activities like investigation and control of diseases, that kind of thing. The IOM, or the Institute of Medicine, defined the following 7 priorities for public health in the 21st century. Understand and emphasize the broad determinants of health, develop a policy focus on population health, strengthen the public health infrastructure, build partnerships, develop systems of accountability, emphasize evidence-based practice, and enhance communication. And so in support of that, the National Academy of Medicine released Public Health 3.0, call to action for public health to meet the challenges of the 21st century. And so it added some more. The recommendations for public health leaders should take on the role of chief health strategists in their communities. Health departments should work with private and public stakeholders in their communities to form partnerships to guide health initiatives. Accreditation of public health departments by the Public Health Accreditation Board should be encouraged and supported to assure all citizens are served by a nationally accredited health department. Timely, reliable, and actionable data should be accessible to communities, and clear metrics should be developed to document success in public health practice to guide, focus, and assess the impact of prevention initiatives, which include targeting the social determinants of health and enhancing health equality. And finally, public health funding should be enhanced and substantially modified by using innovative funding models to expand financial support for both infrastructure and community level work. So issues and trends in public health. Increasing rates of drug resistance to community acquired pathogens. So think tuberculosis, think your staph and some of your strep infections as well. Social issues like welfare reform, racial and ethnic disparities and health outcomes. Behavioral influence issues like chronic disease, violence, substance abuse, emergency preparedness activities, unequal access to healthcare. So these are issues that are facing public health nurses right now. Nurses must keep abreast of the issues that affect society. Assessments need to be changed to include all factors that affect the population they served. And so we've talked about emergency preparedness. We've talked about case managers, education and knowledge for public health nurses. So the Association of Community Health Nursing Educators states the educational preparation of public health nurses should be at least a baccalaureate degree. The core public health competencies are divided into 8 domains. So analytic assessment skills, basic public health science skills, cultural competency skills, communication skills, community dimensions of practice skill, financial planning and management skills, leadership and systems thinking skills, and policy development and program planning skills. Those are the 8 domains. And there is a scope, there's always you can always refer to the scope and standards of public health nursing practice. We look at the 2030 goals for the public health infrastructure. Explore financing of the public health infrastructure, monitor the education of the public health workforce, monitor and understand the public health workforce, increase the number of tribal public health agencies that are accredited, increase the proportion of local public health agencies that are accredited. So those were the goals for Healthy People 2030. Some other Healthy People 2030 regarding immunization and infectious disease areas of focus, vaccine preventable infectious diseases, your STD, sexually transmitted diseases, pneumococcal infections, tuberculosis, healthcare associated infections. So we've talked about functions of the public health previously. Advocate, case manager, referral resource, right? Assessor of literacy, educator, direct primary caregivers, role models, disaster responders. And so there is a nice little chart, figure 28, point one that kind of goes through all of those different roles for you, and gives you some idea of what those roles are. All right, and that finishes this week's lecture. I will see everybody in class on Wednesday. Enjoy the rest of your weekend.